Hey YouTube, my name is Matthew Burr. I'm a second year physical therapy student at Campbell University in North Carolina, and welcome to my YouTube channel. The purpose of this video is to understand why physical therapy as a profession is particularly ineffective or underutilized when it comes to prescribing exercise for their patients following their discharge. Some people might want to refer to personal trainers or other providers for this, but I believe that a doctorate level profession should have more than enough ability to be able to prescribe exercise for the patients following discharge from their care. There might be barriers to this, whether it feels like there's a lack of compensation on the side of the physical therapist, where they feel like they may not get rewarded for this extra effort. There may be a lack of knowledge in general, or there may be a lack of confidence. Hopefully following this video, I will have laid out some reasons as to why physical therapists cannot prescribe exercise or why they choose not to for their patients following discharge, and hopefully we can start implementing this in our practice. The first thing I would like to tackle is the Department of Health and Human Services Physical Activity Guidelines for 2018. What I'm going to do is I'm going to take a deep look at the research methodology, the committee selection, and the strength of evidence when they performed a systematic review of all the various literature that when it came to public health and exercise prescription for the public in general. There are plenty of statistics to suggest that regular adults currently do not meet these guidelines, and we all know that obviously exercise is great for everybody. There's plenty of evidence to support that, so I'm curious as to why many adults currently do not meet these guidelines. Is it a limitation of the guidelines, or maybe is it a limitation of American culture as well? Second, I would like to interview individuals and mentors whom I believe are experts in the field of physical activity and general health and wellness promotion. This will include two Campbell DPT faculty, Dr. Brian Neville and Dr. Carlin Green. The third individual is Dr. Abby King. She is on Stanford's faculty in the School of Medicine, and she was also co-chair in developing the physical activity guidelines for 2018. Lastly, I would like to develop some kind of tool that physical therapists can use to help prescribe patients their exercise following discharge. We're familiar with screenings and questionnaires such as the PARQ Plus, but this won't necessarily give physical therapists any guidance on how to prescribe exercise or how to progress it for their patients following discharge. For Americans. This document came out in 2018. Again, this is from the Department of Health and Human Services. The first thing we're going to do is go through the acknowledgement section and kind of see what group of individuals came up with this document. The second part is we're just going to go over the requirements or the suggestions for active older adults for substantial and additional health benefits. We're also going to dip into the intensity part a little bit, as I feel that part is a little bit hard to understand for the lay person, and hopefully we can come up with a better way that we can grade intensity as we go on. So the first part, again, like I said, to go over the acknowledgments for these co-executive secretaries and additional writing team members. None of these individuals are physical therapists by trade. They either have a PhD, a master's in public health, or a medical doctor. Again, that's kind of disappointing, seeing as our profession are the movement experts, and we are an invaluable resource when it comes to exercise prescription. So hopefully this video can help inspire some change in our policymakers to include physical therapists in the development of future guidelines. Okay, so we're going to go find the key guidelines for adults. So for substantial health benefits, adults should do at least 150 to 300 minutes a week of moderate intensity, or 75 to 150 minutes of vigorous intensity, aerobic physical activity, or an equivalent combination of both. Additionally, adults should also do muscle strengthening activity of moderate or greater intensity, and then involving all major muscle groups on 2 or more days of the week, as those provide additional health benefits. My one caveat here is I would argue that muscle strengthening activities would not be additional health benefits. I think those would be the substantial health benefits. I think there's should almost be a prerequisite or be included with the aerobic physical activity guidelines as being a mandatory recommendation. So getting into the intensity part, like I said, the physical activity guidelines uses METs, or a metabolic equivalent, to kind of judge exercise intensity. And while this is good for research, this might not be the best metric to use for the general population. I think that the layperson will not know what a MET is or what activities have more MET minutes than another unless they read this far into this document. Now, the physical activity guidelines does have this Appendix 1 here that talks about the MET minutes and kind of goes into more detail about what activities go into what minutes and so on and so forth. There's also this link here for the compendium of physical activities that also further in detail kind of goes through what activities are more intense than others. And, if anybody's getting this far into this document, I mean, they kind of have to be either well educated or really, really involved. In my opinion, the better way to choose to measure this intensity is probably through age predicted heart rate max, which they use here for relative intensity. With the frequency and prevalence of the general population using and being comfortable with fitness wearables, smartwatches, Apple Watches, so on and so forth, most of those can somewhat reliably establish a heart rate at rest or during activity. Additionally, I think physical therapists and other providers would definitely feel more comfortable taking a percentage of heart rate max to use an exercise prescription rather than using MET minutes, especially in a post-clinical setting. The strengthening portion of the physical activity guidelines is that muscle strengthening activities of moderate to greater intensity and involving all major muscle groups on 2 or more days of the week is the recommendation that they give. However, they're kind of lacking some nuance when it comes to whether this is intensity or RPE or percentage of one rate max. Like, there's no way to grade any kind of intensity based on the recommendations that they give here. And it says muscle strengthening activities provide additional benefits not found with aerobic activity. I would make the argument that for function in the general population, there is a prerequisite required of muscle strength or power, rate of force development to be able to get out of a chair, get out of bed, or even walk across the street trying to beat traffic. Some of these things, yes, you cannot get from doing just aerobic physical activity. You do need to strengthen your muscles, but I would argue these are not additional benefits. I would think these are prerequisite for function in the community. Again, muscle strengthening activities can also help maintain muscle mass during weight loss. It does not emphasize here how the implementation of resistance training can help stave off the effects of aging, specifically when we talk about these the functional benefits of resistance training. I think this would be emphasized way more if there was some more insight kind of given to it. The other piece of this, again, where it was saying when resistance training is used to enhance muscle strength, 1 set of 8 to 12 reps of each exercise is effective, although 2 or 3 sets may be more effective. This is a seemingly arbitrary kind of like sets and reps scheme. I know that like in people who are trained athletes, a muscle strength kind of reps and set range would be higher weight and lower repetitions here. Again, you can kind of get that, the novice kind of resistance training participant is going to get some strength gains based on this rep scheme just because they're new to this load that's been in place on their body and the demand that they will have to overcome it. However, I don't think this is good enough. This definitely is lacking percentage of 1 rep max. It's lacking RPE. There's no way for a patient to be able to judge where their strength is and relative to where it was weeks ago if they are participating in a resistance training plan. And I think this is a big barrier for physical therapists and other providers when it comes to prescribing resistance exercises, that there's no detailed kind of flow sheet or any kind of detailed formula for them to go through and find out what is difficult for this patient, which of these are driving change, and then how they can adjust on their own kind of moving forward in their plan of care. Physical activity guidelines as far as their recommendations for physical activity for adults. This document here is the Advisory Committee's scientific report. This is kind of an overview of the research methodology that they did to find the evidence to include in the physical activity guidelines. So I'm just going to go through this, a few sections in here, kind of talk about the methodological quality of the review that they did, as well as the applicability. To start in this first section here, again, kind of beating a dead horse, but in their membership list, again, there's no physical therapist involved in the creation of this scientific report. So I think, again, we're being underutilized, and I hope that our policymakers will start to recognize that we are the movement experts. We should definitely be considered when it comes to creating documents of this nature, because we're effective not only at exercise prescription inside the clinic, but outside as well, and in general health and wellness promotion. The other piece that I want to talk about here in this table of contents here is the systematic review literature search methodology. So as we know, like those who are medically trained or at least understand, the hierarchical levels of evidence, is that a systematic review is one of the highest, quality of evidences that we have. They take a large swath of all the evidence that's out there and does a very, particular kind of method of going through each of these reviews and finding which of the evidence is applicable, which is evidence is quality and can be used, specifically like we talk about in a clinical setting, but this is in general health and wellness promotion. The parts that I wanted to talk about here was the systematic review strategy. So they did use a PICO question, which is really good to see. What this does is this kind of, very specifically outlines what their goal was. So you have to have a population, an intervention, or a comparison or outcomes. This is very important when you're going out and trying to find research because it helps you stay specific and stay on your target question. Again, they have inclusion and exclusion criteria here, which is always good. Making sure that there were no things lost in translation. So they found studies that were published in English. They were published in peer-reviewed journals or a high-quality other report that was identified by the committee. And then the other studies had to be existing systematic reviews, meta-analyses, pooled analyses, reports, or original research that were determined to have appropriate suitability and quality by the committee. And again, it had to be in human subjects, of course. Going down here to the other part of developing in the search strategies is the fact that they use 3 databases. It's really good. If they had used one, you're kind of limiting yourself as far as like the total quality or the total quantity of evidence that you can kind of go out and get if you're only choosing one database. But the fact that they choose 3, including Cochrane, that is a very good thing to see here. And again, the core search terms that they have listed here is very extensive as far as aerobic activities or activity, cardiovascular activities or activity, and so on and so forth. Again, kind of listing all this stuff out is really good to kind of understand that they did do a really good job of detailing their methodology and their strategy. And then the other part that I wanted to talk about here was that they did use a really good tool, the AmStar, for assessing the quality of the specific systematic reviews, meta-analyses, and pooled analyses that they used. AmStar is a very good tool that we use to kind of evaluate evidence on our end as well. And then the other piece was also assessing the risk of bias for initial research using the USDA NEL bias assessment tool. The fact that they use one in general is really good. You might find that a lot of research that's out there, they might not go to the extra links to kind of assess the risk of bias, thus kind of diminishing the quality of the evidence that they provide. So all in all, as far as this goes, because I don't want to go too much further into the nuance of this is very good to see. While I may have some problems with, the physical activity guidelines as a whole, as feels like some pieces are missing, I can be sure of the fact that they did do a very good job of kind of assessing the research that was out there and applying it very well into this scientific report. Okay, so now we're with Dr. Brian Neville and Dr. Carlin Green, and they're going to help provide some insight on this topic. So the first question I want to pose to both of you is that do you think that PTs are underutilized when it comes to exercise prescription outside of clinical practice? And whoever wants to answer first, they can.
I think it's a tough question in part because I think so much of our practice setting is built around medical necessity. So when we start talking about being underutilized outside of the clinic, it starts to be a little challenging. My short answer is yes, I think we're underutilized outside the clinic because I feel like I've had the benefit of seeing what PTs can do at the policy level. Mm-hmm. But in terms of day-to-day, I do think that there's a challenge with being outside the clinic when it comes to medical necessity. So I think from a reimbursement standpoint. So I think short answer is yes, but it's more complex than that.
Okay.
Yeah, I think as far as exercise prescription, I think it's just a matter of whether or not we're taking it to that next level as PTs when we have our patients in the clinic, and then whether or not we're putting ourselves in the scenarios like cardiac rehab mm-hmm. or other places where we might be more beneficial, right, whether or not we're actually involving ourselves in those types of settings as opposed to just a standard outpatient orthopedic setting. So.
And I would also add, I think one area that we definitely belong outside the clinic is from a health and wellness standpoint, like mm-hmm. at the prevention level, but also at the wellness level, mm-hmm. continuing past clinical medical necessity within mm-hmm. the walls of the clinic. So I think that there's definitely a role there as well as with policy.
Okay. I'm going to pose this next question like this. Would you be surprised if I told you that no physical therapists were involved in the creation of the 2018 physical activity guidelines?
I would not be surprised.
I would be a little surprised.
Okay, can you expand on that a little bit?
It's hard to know how surprised to be because I'm not exactly sure how large the body is that considers and creates the guidelines. So off the top of my head, right, I mean, if there's a 5-person panel versus a larger governing body that filters, it's hard to know exactly how surprised I would be.
Yeah, so it was the Health and Human Services Secretary appointed an external scientific advisory committee. They were all made up of like MDs and PhDs and masters in public health, and there were no physical therapists included in that group. And there's several individuals on several different subsections, and yeah, I was kind of surprised as well when I saw it too that we were not included in that. So,
Oh, were there any exercise physiologists listed? Okay.
Do you think that physical therapists are hesitant to prescribe exercise at a clinic because they don't know how, or they don't feel like they'll be compensated for it?
Can you repeat the question?
Do you think that physical therapists are hesitant to prescribe exercise outside of the clinic because they either don't know how to properly prescribe exercise out of the clinic, or that they won't be financially compensated for it by their employer?
Want to talk about that one article that?
Yeah,
I'm
so
so fascinated.
I think one caveat and difference of what I'm going to start with is the outside the clinic piece, but I think it's still relevant. There's a study I like to share with the students, and I think I might have shared it briefly with your class. It's a large survey of physiotherapists around the world, and it talks about whether they know the guidelines. If they know the guidelines, what guidelines do they know? Can they name the guideline? Can they describe or explain the guideline? And I remember seeing this, and I think it was about 1,100 physios or whatnot, and the data was striking. And a lot of the hesitancy, or whatever you might want to call it, lack of knowledge, both lack of knowledge and lack of confidence, definitely seemed to be indicated in that study with regard to barriers to implementing exercise prescription. Now, that didn't specify outside the clinic, but I think it certainly would carry over. So I think, and I can't remember the name of the study off the top of my head, but it was within the last few years. And this study really I found interesting because some of the evidence that they showed from the surveys was lack of equipment, lack of resources, lack of confidence, lack of knowledge. So it was a whole host of barriers. And so I think my answer to your question is that based on obviously more than just one study, but I think that helps to shed a light on there's a lot of factors why PTs are uncomfortable prescribing both within and I imagine it extends to outside the clinic. And that includes both lack of knowledge and lack of confidence. I think I would also say that kind of more focused on your question, which is outside of the clinic, I think it's both. I think in my experience, part of the both, if I go on one side of your question, I would say that sometimes PTs may not be as comfortable prescribing outside or beyond the clinic because sometimes PTs may not have as much of a performance background. So they may be able to get their patient from injured to functional, but may have more trouble in terms of knowledge or experience going from functional to competing, for example, if it's an athletic performance kind of thing. I think that compensation or lack of compensation is certainly a barrier because if you're spending hours programming past the clinical episode, then that gets to be problematic from a sustainability standpoint for PTs.
Yeah, I mean that article is absolutely fascinating, and I was surprised by the results of that article. I also think we have to think about clinic norms. That is one of the things that has been shown when we're looking at literature that looks at what a clinic does or does not do. Clinic norms have a lot to do with that. So I think that's a huge thing to consider too, is whether or not it's a norm to take them to the next level from to a performance or competing level. What are other PTs doing around you in the clinic would have a huge impact.
Okay, good. Do you think that the current physical activity guidelines are difficult to follow for the general public? Or do you think it is too difficult for healthcare providers to synthesize that information for their patients? So when we tell them 75 to 150 minutes of moderate to vigorous intensity exercise per week. Do you think that prescription doesn't like come naturally to some people, or do you think most of the public doesn't even know what that means?
I think that's where the breakdown is that the clinicians aren't really sure of what that means, but then the general public isn't either. And so if both parties don't understand, then it just gets neglected completely. And really thinking about, some of the literature goes into like 50 to 70% or 60 to 80% of your heart rate max, and then people just start going, well, I'm not gonna take a heart rate, or I'm not gonna do a blood pressure, or I'm not gonna evaluate what that means for the person that's in front of me. I don't have time for that. So then the PT goes away, not feeling confident in their understanding of what that means. And of course the patient then, because we're writing it in those terms, 60 to 80% of your heart rate max, or even your heart rate reserve on some of the equations, right? A patient is going to have a hard time following that as well. So I really do think it's both.
Yeah, and I think time, you mentioned time, I think that's a massive barrier. I feel like it's not true of just PTs, but other medical professionals, even more than PTs sometimes. I've accompanied family, for example, to medical appointments where a physician may have counseled to eat better and exercise, but the depth of that conversation, there's not enough time to go into those details, even if somebody as a practitioner feels comfortable sharing the details or guiding through details. So I agree. I think it's both. I think it's a particular depth that a provider might be comfortable with, but also maybe time restricted on. And on the receiving side, I think patients often don't have necessarily the health literacy to implement that. And I think I would take it one step further and go beyond your question and say, because you kind of set up a binary thing, and I think that even if the provider could provide that information, even if the patient could understand that information, which are caveats, I think the readiness to change in our culture and our society is kind of lurking in the background there.
I agree. And then one of my last questions I got here is that, do you think that participation in exercise by physical therapists will further incline them to prescribe exercise for their patients following discharge?
Like if I'm a PT and I like to exercise, that would make me more inclined. That's a hard question.
I absolutely think so. I say that because I feel like I think modeling what you hope your patients will do is key, right? I think actions speak louder than words, and I think, and I don't mean that just in terms of knowledge, right? I mean, I think there's a level of street credibility, so to speak, when if I'm going to see a medical provider and they're modeling the way for me, then I know it's achievable. I know they have the knowledge to achieve it because they're demonstrating it to me. On the other side of the coin, it's really difficult to have a medical provider, for example, say you should really consider smoking cessation if they smell like smoke, right? I mean, and that's a different thing, but has some parallels here. So I absolutely think so. I also think that one of our best assets as PTs is to inspire people. And I think the best way we can inspire people is to show up and show them through actions that we're doing. Like, I would never ask a patient to do something I was not willing to do myself. I think that's really powerful. So.
Yeah, on a very personal level, I feel like it is my job to set an example and to show people that it is achievable. And I feel like that even more, like the older I get, the more I want to be an example that, aging doesn't have to mean fragility, and it doesn't have to mean, weakness, and right. So I on a personal level, I feel that way. I'm just not sure as a whole, like, as a profession, if I know the pulse of PTs. What an interesting research study.
Well, I wouldn't say it's a requirement, right? I mean, it's like some of the best sports coaches are not the ones who are on the field, right? I mean, the knowledge is obviously the most important foundation. I think there's an added layer of inspiration if a PT can do that.
Great.
Okay, great. Thank you both so much.
Awesome. Thank you.
Appreciate it.
My exercise prescription tool, or EP tool for short. This is just something I've developed over the weeks of developing this video, just to kind of get a better idea of how physical therapists can prescribe exercise to their patients after their discharge outside of clinics. So hopefully this little flow sheet will give PTs and other providers a better idea and hopefully a good framework to kind of judge exercise prescription based off of. So the first part here is just, has your patient filled out a PAR-Q Plus or other survey to clear them from exercise? Hopefully they have in this scenario, and if they have, this will kind of cover you as far as if anything happens during their exercise prescription after the fact. Some clinics might have had their patients fill these out in the clinic. So just kind of having this, and then if not, filling out that or some other kind of survey or getting clearance from another doctor or you before participating in this exercise plan. So the other part here is, has your patient had an appropriate cardiovascular and pulmonary response to exercise thus far? So like appropriate increases in heart rate, systolic blood pressure, etc. Just making sure you kind of take a look at this as you have your patient in clinic, as if they're responding good to exercise that you've prescribed thus far. Hopefully this shouldn't be a problem. So yes and yes. And then this goes to the other sides of the aerobic prescription and the resistance prescription. So we'll start with the aerobic first. And then we kind of just laid out only moderate intensity exercise here per what the physical activity guidelines had. Obviously, you'd want to start out a novice exerciser to, light levels of intensity so they can kind of get an idea of it. So for the aerobic prescription, finding a mode of exercise appropriate and salient for the patient, such as walking, jogging, or swimming based on equipment availability. Obviously, some patients might be limited in terms of either gym access, or if they have equipment or lack thereof at home, or if they don't have a local greenway trail or something that they can get to, then this is kind of up to you as a physical therapist to kind of find, what exercise mode is going to be most appropriate for them based on this. Using this heart rate max calculation here, this one is a little bit more accurate than the 220 minus the age, but you'd have 208 minus 0.7 time the patient age, and that would be the heart rate max. Again, then basing intensity off of a percentage off the heart rate max. And then frequency here, prescribing enough sessions to achieve 150 to 300 minutes of weekly moderate intensity exercise. And then down here, I have a little note that just says, remember that aerobic physical activity can be a combination of both moderate and vigorous intensity exercise. They don't have to be exclusive. So if you have only, 85 minutes of moderate intensity exercise, but then you have 45 minutes of this, you at least have a combination of both. So going down here to the vigorous one, finding another mode, again, based on equipment availability, use the same heart rate max equation as the moderate, and then you're just taking 77 up to 95% of the heart rate max. And then for here, I had prescribed enough sessions to achieve 75 to 150 minutes. Again, this can be, I have 2 to 3 here. That's just a recommendation. You can have whatever frequency of sessions that is going to be most attainable for your patient. So that's the aerobic piece. And then going over here to the resistance piece is the moderate intensity. So finding another mode, again, appropriate and salient for the patient, whether this is functional tasks, general strength training, hypertrophy, and plyometrics, etc. Incorporating, the multiple groups and upper and lower body, like per the physical activity guidelines. Determining a 1 rep max or a 10 rep max, adjusting resistance to get close to mechanical failure in the last rep of the last set. This can vary depending on what mode of exercise you choose, but just kind of, at least for their first session, keeping an eye on them where they feel like they wouldn't be able to complete one more repetition. Again, using RPE for this as a proxy for intensity. So RPE 6 out of 10 for moderate, or a 50 to 70% of the 1 rep max. And you could say the same thing for the 10 rep max. And I'll have starting at 3 sets of 8 to 12 and progress. Again, this was a set and rep scheme that I wasn't a huge fan of from the physical activity guidelines. However, this is kind of the cookie cutter starting point. What I wish that the physical activity guidelines said was like, please, adjust appropriately depending upon their goals. And that part was missing from there. So use your clinical, your clinical reasoning and your clinical expertise to progress your patient depending on this. And then for the vigorous intensity exercise, kind of the same deal. You increase the RPE from 6 to 8.5 out of 10, or 70 to 85% of the 1 rep max to the 10 rep max. And then this for here, you're going to have more sets with fewer repetitions per set, and then progress depending on the specificity of training. So that's kind of it for this, and then kind of the end of the video. I will link this as well as all the other resources that I use in the description. And please like and subscribe, comment. Would love to get other providers' thoughts on this. So thank you and have a great day.